السلام عليكم ورحمة الله وبركاته. In today's video, we'll talk about case presentation of Kawasaki disease, which was published in a curious journal by a group of Moroccan medical professionals working in Mohammed VI University Hospital in Oujda. But before diving into the case presentation, let us discuss a little bit about this disease, its clinical diagnosis, etiology, epidemiology, and of course its treatment. Kawasaki disease, aka mucocutaneous lymph node syndrome, is an acute necrotizing vasculitis which affects mainly medium-sized blood vessels, with a particular predilection for coronary arteries. Despite the cause of Kawasaki disease remains uncertain, it is associated with infectious and genetic factors, where the prevalence is much more higher in patients of Asian descent and in siblings of affected children. It primarily affects children under 5 years, and it is considered as the most common cause for acquired coronary artery disease in children, where the mortality is mostly due to myocardial infarction and arrhythmia. The clinical diagnosis requires a fever for at least 5 days with one of the following: at least 4 of other specific symptoms, or less than 4 specific symptoms with involvement of coronary arteries. The specific symptoms include erythema and edema of hands and feet, including palms and soles in the first week, with a possible discomation of fingertips in glove-like pattern after 2 to 3 weeks, with a polymorphous wash originating on the trunk, a bilateral eye injection or conjunctivitis without exudate, an oropharyngeal mucositis, including erythema and swelling of the tongue, given the aspect of strawberry tongue, and cracked and red lips, and finally a cervical lymphadenopathy, mostly unilateral. But be alert, because there is more non-specific symptoms which may precede the onset of this disease, including diarrhea, fatigue, abdominal pain, arthritis, hoarseness, and breathing difficulties. All these clinical symptoms may be reassembled into a mnemonic: crash and burn, where each letter stands for symptom. The C stands for conjunctivitis, the R for rash, A for adenopathy, the S for strawberry tongue, and the H for hands and feet discomation. And burn stands for fever for at least 5 days. It is worth mentioning that Kawasaki disease is a clinical diagnosis. However, it is supported by the following diagnostic findings. First, the lab findings: we will see an elevation in inflammatory markers, an elevation in ESR or erythrocyte sedimentation rate, and elevation in CRP or C-reactive protein. Also, a leukocytosis, a thrombocytosis, and in rare cases a thrombocytopenia, and also an elevation in hepatic enzymes AST and ALT. The second paraclinical exam is echocardiography, which allows us to evaluate coronary arteries aneurysms, which is an abnormal dilation of an artery due to a weakened blood vessel wall. It is worth mentioning here also that the risk of aneurysms is highest during the 2nd and the 3rd weeks following symptom onset. As for the treatment, we give patients IVIG, or intravenous immunoglobulin, with a high single dose to reduce the risk of coronary artery aneurysms, and it is most effective within the first 10 days following disease onset. And secondly, a high dose of oral aspirin. But when you hear children plus aspirin, that should ring a bell, because to avoid the risk of Rey syndrome, children shouldn't be treated with aspirin, especially if a viral infection is suspected. However, Kawasaki disease is one of the rarest exceptions to this rule. And now, let us move into the case presentation. The case presentation is about a 2-year and 10-month-old girl with no notable medical history who was admitted to our department for a febrile rash that had been evolving for 7 days prior. So we have a febrile rash and a fever for at least 5 days. Her admission laboratory results revealed leukocytosis at 21,770 elements per millimeter cube, with neutrophils at 17,220 elements per millimeter cube, lymphocytes at 3,890 elements per millimeter cube, and monocytes at 990 elements per millimeter cube, with a hypochromic microcytic inflammatory anemia, with a hemoglobin at 10.4 gram per deciliter, mean corpuscular volume at 78.60 femtoliter, a mean corpuscular hemoglobin concentration at 27.50 gram per deciliter, and ferritin level at 443 mg per liter, a thrombocytopenia at 91,000 per millimeter cube, an elevated CRP or C-reactive protein at 403 mg per liter. So, for now we have a febrile rash with a fever for at least 5 days, a thrombocytopenia, a leukocytosis with an elevation in inflammatory markers, specifically CRP, and accelerated sedimentation rate at 99 mm, with a significantly elevated BMP at 2,641 international units. The ECG was normal and troponin levels were normal. Serologies were also performed for CMV, Epstein-Barr virus, TORCH infections were negative. The prothrombin or TP time was prolonged, and the peripheral blood smear revealed the presence of schistocytes, helmet cells, and platelet clumps. On the paraclinical level, the cardiac ultrasound revealed coronary dilation. Based on the clinical criteria, we diagnosed her with Kawasaki disease after discussing potential causes of thrombocytopenia, including probable disseminated intravascular coagulation and macrophage activation syndrome. In terms of treatment, the patient received an emergency infusion of intravenous immunoglobulin, or IVIG, at a dose of 2 gram per kilogram, along with anti-inflammatory acetylsalicylic acid, or aspirin, with a dose of 80 mg per kilogram per day. 2 days later, due to persistent fever, our patient received a second dose of IVIG and was reassessed the following day. Clinically, she achieved afebrile status from the first day, and her platelet count increased from an initial of 91,000 to 142,000, while CRP levels showed a decreasing trend from an initial of 403 to 133. 3 days later, desquamation appeared on the palms of her hands and the soles of her feet, in a glove-like fashion, which is typical of Kawasaki disease, as shown in the following picture. Her platelet count reached 957,000 elements per millimeter cube, with the CRP levels at 8.31 mg per liter. Now, in the discussion part, they have mentioned that certain clinical signs, although not included in the diagnostic criteria, should raise suspicion of Kawasaki disease. These include behavioral changes with significant irritability and the presence of erythema at the site of BCG scar. Also, thrombocytopenia is an unusual form of KD and has been rarely reported in the literature, with a prevalence of 3% in Chinese series. The gold standard treatment is IVIG at a dose of 2 grams per kilogram, along with an anti-inflammatory dose of acetylsalicylic acid or aspirin with a dose of 80 to 100 milligrams per kilogram per day in the acute phase. Subsequently, most North American teams reduced the dose of acetylsalicylic acid to an antiplatelet dose of 3 to 5 milligrams per kilogram per day after 48 to 72 hours of defervescence, and continue it for 6 weeks or longer if coronary abnormalities are present. Also, several studies have investigated the relationship between Kawasaki disease and thrombocytopenia. For example, a study was conducted involving 303 patients with Kawasaki disease, among whom 10 patients with a concurrent thrombocytopenia. They found that 6 out of 10 patients with thrombocytopenia, or 60%, developed aneurysms, while among the remaining 293 patients, only 8.9% developed aneurysms. Thus, thrombocytopenia may be a risk factor for coronary arteries aneurysms during the acute phase of KD. They have also mentioned that there are various theories regarding the mechanism of thrombocytopenia in individuals with this disease. It has been hypothesized that thrombocytopenia is secondary to platelet consumption induced by coagulation, as evidenced by abnormal coagulation tests and the presence of disseminated intravascular coagulation in these patients, while others attribute it to an increased platelet destruction by IgGs or non-immune mechanisms like binding of an infectious agent to platelets. In conclusion, we have seen in this case report that the patient had almost the typical table of Kawasaki disease. However, thrombocytopenia is a rare feature of this disease. Thus, clinicians must be aware that thrombocytopenia may have a high risk of developing coronary artery aneurysms and myocardial infarction. Thanks for your attention.